take too much time. Lovely.
Right then. Fire away, go for it.
Okay, lovely. So we're here to welcome Professor Fares Haddad today for a question and answer for Active Body Clinic. And he's kindly agreed to do this. So thank you very much for agreeing to do this for me, Professor Haddad. It's great to have you here. So for those of you who don't know, Professor Haddad is a hip, knee and sports specialist orthopaedic surgeon working predominantly in the NHS out of ISEH and his private practice at 30 Devonshire Street in the Wellington. So if you do need him, I will be putting his details for his private practice up at the end of this Q&A. He's also the director of the Institute of Sport and Exercise and Health, and he's also the chief medical officer for the NFL in the UK. And he's carrying out a lot of interesting current research, which we're going to hopefully talk about in a minute. So if you're ready, are you happy for me to fire away?
Go for it.
Lovely.
Go for it.
So you're currently doing a lot of research into various topics, including joint preservation techniques, surgery on infected joints, and robotic procedures. Could you tell me if there's any area of the interest that you're most excited about with your current research and how you think that might benefit patients going forward?
Sure. I mean, we're very lucky that we have great teams and we've got multiple research streams running. So they've all got really interesting developments and things to talk about. Probably the most exciting thing, the thing that's changed radically over the last 3 or 4 years and that will evolve massively over the next decade is robotic surgery. The reality is that has already transformed joint replacement to a better place. It gives us the ability to three-dimensionally plan, essentially to decide exactly what each patient needs and to deliver that very accurately, very precisely, so that if you need to partially resurface a joint, you can put that exactly where it needs to be. If you need a full replacement, you can make sure it's completely balanced. If you're doing a hip replacement, you can get the length, the rotation, the version all right and not get any impingement. So that ability to three-dimensionally plan, to then execute that personalized plan with great accuracy is phenomenal. So we're in a place where that is truly exciting. We've got 4 randomized trials running. We've just had a couple of national studies funded and the pipeline that's coming behind research-wise, which takes, as you probably imagine, Charlotte, takes years and years to get from the lab all the way through to the patient is truly exciting. So right now, the robot, if you like, the orthopedic robot, is a tool that the surgeon holds, that you decide when to start, when to stop, but it won't let you cut too far. It's going to get much more sophisticated. There'll be some artificial intelligence and machine learning in it. So if there's one thing, and that's really going to change for everybody, it's the use of robotics. And right now it's in joint replacement, but it won't be that long till it will be able to help with things like osteotomies or ligament reconstructions. So that's an area to watch out for.
What sort of time frame do you expect this to be available regularly as opposed to just through the clinical trials?
So it's in clinical trials, but actually it is already available regularly in various centres around the country. Okay. We had the first Mako robot in England that we got about 4 years ago at the Princess Grace. Yeah. We will now have 3 at UCH, but there's almost 30 around the country now. And like all these things, it's not just the machine, it's how the machine is used. Yeah. But the reality is that the technology is really very exciting. And certainly in terms of, your older patients who are needing knee replacements, is transformative.
Yeah, I can well imagine. And I'm guessing it would make my job quite a lot easier as well, if everything's completely balanced out. Lovely.
No, and you're right, just direct practical. So we've shown that, for example, let's take knee replacement as an example, or partial knee replacement with both sets of patients, less physio interventions, less swelling, less pain medication. So patients have less trauma to the joint and so they mobilize more quickly. So your job will be much easier. You can spend a bit more time, muscle activation, gait re-education, rather than just reducing the swelling and the bruising.
So definitely reducing that acute phase for everybody and pain, hopefully, as well then. Yeah, lovely.
Which is a big thing.
No, that is very exciting. Brilliant. Lovely. So another area of your current research is around using stem cells and coatings to enhance implantation and osseointegration of these joints. Could you give us a little bit of information about that and how it works and how that enhances things for you?
Yeah, so that's mainly been lab-based research, and the premise here really is when we put an implant in, be that in the knee and the hip or outside my area, the shoulder or the ankle, There are broadly two ways of fixing it. The traditional way is by grouting the implant in with some form of bone cement. The more modern way has been to try and put the implant in without cement by getting a press fit and getting it just to be captured by the bone. If you do that, what you really want is for then the bone to grow into the implant, and therefore the implant will become part of your body. So if you're doing a hip replacement, for example, there is a stem that goes into the femur and a socket that goes into the pelvis, into the acetabulum. If both of those have surfaces that the bone will grow into, then effectively you have a hip that is part of you for life. And if anything's going to wear out, it'll only be the bearing. And bear in mind, we're using ceramic bearings that really don't wear much. So the dream that in my lifetime we'll be putting in hip replacements and never having to come back to them again, would then become a reality. Now, in native bone, in first-time round surgery, we're pretty good at getting osseointegration just by having special surface coatings on implants. But in revisions, in redos where the bone's been damaged, either by previous surgery or by radiation or by infection or something else, it's tougher to get that mating between the bone and the metal. And so the idea is by using stem cells, we can do that. That's been successful in the lab. We've yet to finish the studies in beyond the experimental phase yet, but it's an exciting thing again for the future.
Can I ask you maybe a stupid question? The coatings that you're currently using that you were saying help with the osseointegration, what are they composed of?
When you say primarily it's something called hydroxyapatite. So essentially it is you need a rough surface and then hydroxyapatite, which bone likes growing into. And in fact, in a primary setting, that's very successful. There is a fallacy. People believe if they have a joint replacement that it will only last 10 years. But actually, we've got pretty good longitudinal data. You would be really upset if your hip replacement didn't last 20, 25 years in the modern age.
Yeah.
So, most patients who need a hip replacement, by the time they have it, they wish they'd had it done earlier.
Yeah. I think you've frozen a bit.
10 years is not a long time, but much longer.
Now, my next question is, we see quite a lot of guys with ACL and ladies with ACL ruptures in clinic, and we have obviously working in rugby, we have a few, and you've done a fair few of our boys with a hamstring graft. I often get asked with patients, I mean, granted, they've all been successful as well. We've not had a re-rupture or any issues with them, so I'm obviously a fan of the hamstring graft myself too. But I wanted to ask what your clinical considerations are when choosing between hamstring, patella tendon, or perhaps even a donor graft, because we get asked this by patients quite a lot when they're aware that other people have had different surgeries and different surgeons using different techniques.
Yeah, I mean, it's a great question because actually there isn't a perfect answer.
Yeah.
And the choice will largely be based on the patient. So a hamstring graft is probably still the most popular in my hands, but then we do quite a few patella tendon or increasingly these days quadriceps grafts. All work pretty well.
Yeah.
All work equally well in the studies. It's all about the donor site morbidity. So to me, it's always been slightly less risk to the patient and less donor site morbidity to use a hamstring graft than use a patella tendon graft because of the risk of anterior knee pain and stiffness that's slightly greater with a patella tendon graft. But it does equally work if someone would prefer that. The advantage of the hamstring is less pain, smaller scar, slightly quicker recovery. The advantage of the patella tendon is that it's a bone fix to the apertures, to the bone tunnels, and therefore it is potentially more solid. The reality these days, if someone's very, very unstable, we will also add something called an extra-articular tenodesis. So we will tighten up the ITB and put it under the lateral collateral on the outer side of the knee, which to me makes the hamstring graft a very sort of relatively painless and secure way of doing that, rather than having both a patella tendon scar and a lateral scar very close together.
Yeah.
And nowadays, as you know, Charlotte, in elite sport, most of our guys end up with an extra-articular tenodesis because, those guys can't afford, they lose one season, they can't afford to lose two.
Yeah. Could you just explain with the tenodesis in regards to joint mechanics, how that stabilises the joint in an extra capacity, should we say? Just for people who don't know the anatomy.
So I'm going to try and do this.
No, go for it.
So if this is the knee joint, and I haven't got an artificial knee joint to show you here.
Fine.
When you're fixing the ACL, it's right in the middle of the knee joint, and therefore it controls the front to back movement pretty well, but it struggles to control rotation. If, on the other hand, you can tighten on the side as well, which is what the extra-articular does, that's a much better way of controlling rotation. And so by taking that strip of ITB that's connected to the tibia and then routing it under the lateral collateral and back down, that gives us very secure control of the pivot, which is really the important thing about an ACL injury, is the pivoting maneuver.
Yeah. And do you have any knowledge of how, if there's been any studies with the tenodesis, of how much that reduces the re-rupture rate? Or is that something?
No, there is, and we've published one series about 3 or 4 years ago. But basically, it less than halves it. So now we've sort of clarified our indications. So we'll tend to do a tenodesis in elite athletes because they come back pretty aggressively. In anyone who's hypermobile, lots of hyperextension. Anyone with a grade 3 pivot, really strong jump when you pivot their knee. And in anyone who's failed a previous ACL reconstruction that was done properly. So every year I'll be referred 30, 40 ACL reconstructions that have been done elsewhere, usually done perfectly competently, but they failed.
Yeah.
And in general, one of the reasons is residual rotational stability. So by doing the extra-articular tenodesis, we add extra stability.
Lovely, great. Thank you very much. The next question is, you're specialised in surgical repair of proximal hamstring detachments, and I know a few people that you've done that, and I think you've done a rather famous footballer recently who we shall remain nameless. We've had patients with partial disruptions from varying levels of sport, so I wondered what your clinical considerations were for this, whether to go surgical or conservative management with a partial disruption, and obviously that will depend partly on their level of sport. But if we're looking at, say, elite athletes or semi-professional, for instance, what would your considerations be with making that choice?
Yeah, no, it's a really good question, and to a lot of people, the concept of hamstring surgery is a strange one. People say the hamstring, you wait for it to heal. That was the old way. And in reality, MRI scanning has improved so dramatically that our understanding of hamstring anatomy has evolved. And in your world and in my world, jackling in rugby has been a source of huge numbers of hamstring injuries because, trying to stay on your feet and someone landing on your back, suddenly you're hyperflexed and the hamstring comes off. So we're seeing more and more, so we've learned more and more. And the reality is, it's all about getting them appropriately investigated early. The sort of clinical bit is, if you see a bruise with a hamstring injury, always get an MRI scan. Then, in terms of your question, the MRI scan, if properly interpreted, will define what we should or should not do. If you've just got a partial injury at the origin, those have a pretty good chance of healing well. And in those in whom they do not heal well, they'll leave some tendinopathy-like symptoms, some discomfort, but they can always be fixed later. If there is displacement, though, you're better off having it fixed. All sorts of problems. There's a so-called hamstring syndrome that happens if you don't fix them back. People have ongoing hamstring pain and irritability. So a partial tear at the origin can be left alone for most people, apart from some of the elite who just won't tolerate that risk of waiting and finding out that things aren't right. Once you're down to the muscular tendinous junctions, particularly the distal tears. So let's take an example. If you tear the distal biceps at the junction of the long head and the short head, the other consideration is recurrence. So we know that if you have that T-junction tear between the long and the short head of biceps, you've got a 40 to 50% risk of recurrence if you're in a sprinting sport. So that's an injury where if you see that gap, if you can feel that gap, it just makes more sense to repair it because the recovery time frame is the same surgically or non-surgically. For the majority of non-elites, if you see a big hamstring injury in the tendon rather than a pull-off either end, it's really about just taking the time and doing appropriate rehab. Most of them don't need surgery, but they do need at least 3 months for the tendon to remodel and heal sufficiently well for them to be able to come back to action. So this is one area where there's definitely, if you like, a bit of a rule for the elite. You need to come back to very high speed running and need to limit their recurrence rate, and a rule for the rest of us where, frankly, I'm never going to run at a speed that threatens my hamstrings significantly.
Oh, you never know. For physios then and sports therapists and osteopaths and people working with these people in elite sport, what would you say clinically when you assess somebody, other than bruising, would be the things to look for to make sure that you referred that more urgently? Because obviously standard practice really with hamstring injuries isn't to refer for something like that straight away. So what would you say we should be looking out for in that regard?
So I think, thresholds are a pop, a neural presentation, someone who is limping the next day, and bruising. I think those are all, someone whose outer range contraction is considerably weaker than normal, for example, that for me is a red flag.
Okay.
And the availability of MRI scan these days it is such a shame to miss a significant, easily remediable injury. And you don't want to bring someone back too early. Even we're not necessarily talking about surgery. It's the fact that someone settling down, coming back at 3 or 4 weeks and then re-injuring versus taking 3 months and coming back and not re-injuring is a big deal even for the amateur athlete. And so all those things, I think, the pop, the neural presentation, the difficulty generating a contraction, the person who doesn't settle down after 5 or 6 days, it would be a good idea to image.
Okay, great. And you mentioned hamstring syndrome. So with these injuries that aren't picked up or aren't dealt with in the adequate way, would you expect that could affect them neurologically because of obviously the anatomy and how close the nerves are? And also, can that happen post-op as well?
Absolutely. So, the biggest thing is, if you look at where the biceps tendon and the semimembranosus tendon run, they're twinned with the sciatic nerve. It literally runs right next to them. And so any bleeding in that area is liable to cause scarring or tethering of the sciatic nerve, particularly if you have enough trauma, if you're playing rugby or water skiing and the tendon pulls off the top and it all bunches up with the sciatic nerve. That can be pretty serious and that can cause a lot of pain. And, when you see some of our amazing, people who play rugby to the top level and suddenly are screaming on the pitch with a hamstring injury, that's not so much the hamstring, that's the neural stretch that happens when they tear that hamstring. It's pretty horrible. So those get stuck down and that can be pretty unpleasant.
Okay.
It can also happen after surgery. Surgery is a trauma after all. And that's why we try and get people moving as quickly as possible after surgery. So, again, like everything else, everything I do, the physio is more important than the surgery, quite frankly. All the surgery I do is pretty straightforward. It's about making the right decision, picking the right patient, doing the right operation, but ultimately getting the right rehab in place. Because if you let something scar down, it's not going to do well.
No, I would say 50-50 though, to be honest.
So, take the credit.
We'll go 50-50. And lastly on that point, is there a window? You said obviously we can delay the repair and wait and see in certain patients. Is there a window though for that repair? And how long is that, if there is?
The earlier the better is the easy answer. For the avulsions, anything up to 6 weeks is still reasonable.
Okay.
Beyond 6 weeks, it gets tougher. It means longer in a brace, slower rehab. For the muscular tendinous injuries, they really do become a pain after 3 weeks, 4 weeks. So you really need to get those diagnosed really early.
Okay, lovely. Thank you. My next question is about stem cell and PRP for osteoarthritis. I haven't actually treated a patient who's had this yet, but I've had somebody contact me recently about this, and there's clinics popping up, places that are offering injection therapy with stem cells and PRP for osteoarthritis. Now, we do deal with quite a lot of patients that have had PRP for tendon issues, but I've never dealt with a patient with OA. I just wondered what your thoughts are on this intervention, because it costs a lot of money, and I just wondered whether it's you think it's a reasonable intervention to make.
So I think you should split them apart, really.
Okay.
So
yeah.
PRP, and there are lots of different types of PRPs. Again, you've got to be pretty careful. There are some types of PRP for which there is low-level evidence that they will alleviate symptoms. Okay. And I think we've got to be clear here. The PRP is doing the same sort of thing that a steroid injection or a hyaluronic acid injection would do. It is relieving someone's symptoms for a while. It's not regenerating their joint. It's not recreating cartilage. So there is a little bit of something behind PRP. The so-called stem cells are unfortunate because that's false hope.
Yeah.
The reality is most of those preparations that are being marketed out there at the moment, and you're right, There are lots of those clinics out there with beautiful websites, lots of advertising, and several £1,000 to go and give some of your fat or some of your bone marrow to be spun down and then injected into your joint. There's really very little, if no, stem cells in that, and the evidence base is next to zero. There really is no evidence base for that. There's two things really. One is it's living on hope, because patients don't want surgery, they don't want to be disabled, they don't want, they would love to have something to reverse the process. I think that the other dangerous thing is it is going to delay the real stem cell developments, because there are actually preparations that are 100,000 times more concentrated, the sort of things we use for bone marrow transplants, not in my specialty. And so the ability to generate stem cells, to cause them to multiply, is there. And that costs lots of money. And that's what we need to develop, and that's what we need to do research on. At the moment, I'm afraid most of those sort of regenerative type stem cell things that make various newspapers and are out there on the web are not real treatments. They're not evidence-based treatments.
Yeah. I had a look for some evidence-based research on the stem cells and couldn't really find any positive evidence-based research for it. So I thought I would ask your opinion, because it's not something that I know much about. So, yeah.
And for your patients, the reality is that there'll be lots of patient testimonials, but what you'll find is if you go and offer yourself up for that, you will also at the same time commit to losing weight, commit to doing exercise, see a physiotherapist, do all the other things. By the time you spent £5,000, £7,000, £8,000 doing that, you will do all the other things. It's tough to differentiate the effect of exercise and physio from the effect of what may be a non-effective injection.
And I'm guessing as well, they probably don't follow them up 5 years later.
I think the data you'll find is very short term. It's a phone call, it's a short term phone call to say someone's doing very well. I mean, I think the other thing is, you may be aware, we discussed this previously in the press, in that we've seen complications from that sort of thing. We've seen infections. We've seen people try and inject stem cells by doing an arthroscopy, and the morbidity from having general anesthetic and so on. So I think people should approach their care with caution. Nobody wants to have surgery, but sometimes it's better not to do any intervention at all, or do an intervention that works, than fall in between for these things that are kind of marketed as benign, but are not always benign. They're expensive and they may cause harm.
Okay, that's great to know, and it helps to protect patients as well from paying a lot of money for something that doesn't really have the evidence-based research. And I think as well, if they are doing things like that and delaying, if they have severe OA of the knee, then I would imagine the effect that's going to have higher up on the hip and the lower back as well, prior to them actually having surgery, isn't worth it either. So it causes more problems than it solves. But thank you, that's really interesting. What are the most important things that you think patients can do to help themselves after they've had a surgical procedure? And I'd like them to hear this from you.
The reality is, I think it starts before surgery, and that's understanding what they're going to do, preparing, so what we call prehabilitation, coming in fit, strong, lean as they can, and then having good communication and having a team around them. So as I said before, I think the most critical thing about any operation is what you put around it. It's the rehabilitation, it's the help and recovery, it's having access to people to advise you, because no matter how much you read and how much you try and learn, there'll be things that happen in the period after surgery that you don't expect and you don't have a benchmark for. So I think good communication, having appropriate preparation, and having a team around you that includes your physio, that your icing machine, all the other bits and pieces that you need. But actually it's information, preparation, communication, just so that there is a team there to help you get better.
Okay, lovely. If you don't mind and you have the time, I've got one more question that's just popped into my strange little mind. I just wondered what your thoughts are. We've had a couple of young rugby players and actually a cricketer as well who ruptured ACLs and have been offered a repair of the ACL as opposed to a reconstruction. And I did ask this question to a surgeon on one of your webinars the other day, and he's not a fan of the repair. He said he doesn't think it. I just want to know what your opinion is on that, because I've seen I didn't have patients being recommended to have repairs sort of 5 years ago, but in the last couple of years I've started to have that a few more with the adolescent athletes. I just wonder what your thoughts are on that.
Yeah, so it's something that's come to the fore again, and it keeps recurring. There were randomized studies 30 years ago that showed reconstruction was better. There is some really nice basic science research from a lady called Martha Murray in Boston showing that there's potential if you use the bioscaffold and put some growth factors around it, that there may be some success. And the NFL Players Association has backed some studies from that. So with her particular device, there may be hope. In reality, most of the repairs that people are talking about are just putting a synthetic material across the ACL and fixing it in the femur and the tibia, and so-called internal brace. And for that, frankly, there's no evidence. It's just something, again, a very clever company, good marketing, but we shouldn't dismiss it completely. So if you have a pull-off on the femoral side, so if you have an ACL avulsion rather than a mid-substance rupture, if it's not disorganized, then actually trying to put that back is probably a sensible thing to do. So ultimately, I think it's a very individualized decision. It's based on the nature of a tear. And if it's a tear off one side, particularly the femur, or the other, and the structure is preserved, there is some credibility to repair. I think that, so there are some patients for whom it's a good idea. I think the warning to everybody is patients should not be rushed into an operation just because it can be repaired rather than reconstructed later, because some patients may never need that reconstruction, particularly those who aren't involved in twisting and turning sports. And there's a big fallacy that if you have to have a repair, well, if it doesn't work, you just have a reconstruction. But actually, if you have a repair and it doesn't work, there's a lot of hardware in there, and it's not as straightforward as a first-time round reconstruction. So you've got to be a little bit careful. So I've revised half a dozen repairs in the last year. So they don't always go swimmingly. But the key thing is probably if you're looking at it, it's the anatomy of the tear.
Very much. Thank you for your time. I know you're a very busy man, and I really appreciate it. And I think it's been really informative, and some very exciting comments about your future research. Especially, I'm really excited about this stem cell coating for joints, because I think that could make a massive difference to people. So I really appreciate everything for today, and hopefully we can get back to some element of normality at some point soon. It's actually weird talking to someone without a face mask on at the moment.
We're definitely socially distant, Charlotte.
We are socially distanced, exactly. So keep well, and I'm sure I'll be sending some more people your way. Lovely. I'll see you soon. Thank you very much.
Take care. Bye bye.
Bye bye.